I couldn't agree more. So thank you so much. You have played such an important role to give this whole adult care a boost. And that immediately kind of connects us to the next speaker, because a lot of this work was funded by the Muscular Dystrophy UK, which is really fantastic. They did this, but they did more. And that is we discussed with them like almost a year ago, like how to translate this information to the lay public. How can we, all the things which are described in this adult care guidelines, make available for the patients? And again, Muscular Dystrophy UK started a project, and now I will give the microphone, let's say, to Michaela, because she's the one who worked on this project and who will tell how they made this information available for patients. And we will also together look how we can make this available for the whole world, let's say. So Michaela, the floor is yours.
Thank you, Elizabeth. I appreciate that. And yes, I've got to say, I think it's nice that I'm able to present here today, because these videos have been a really exciting piece of work that Ros and I have been working on a lot. So as always, she's got her many pots in the air that she's been working on. So thank you so much for everyone that's let me come today. My name is Michaela Regan. I'm the Head of Policy and Campaigns at Muscular Dystrophy UK. Can we have the next slide, please? So as I'm sure everyone's been hearing about today, we do have a growing number of adults with Duchenne muscular dystrophy, which is a really exciting time for them. But this also comes with their own complexity, where they have different care needs than children. And I'm sure you've all heard that we've published an Adult North Star Network consensus guideline for adults to reflect the different care needs that are different from pediatrics, and the sort of complex care that needs to be considered when you're supporting them as best we can. This covers a wide range of clinical areas such as neurology, cardiology, respiratory, all the way down to anesthetics and psychology. Since then, we've also published another document, which I'm not sure everyone's aware of, is a therapist-specific care guideline, which covers physiotherapists, occupational therapists, and speech and language therapists, and gives advice to those therapists who've got little to no experience of supporting a patient with Duchenne, just the key core messages of what they need to know. Now, as Elizabeth mentioned, and Ros has mentioned as well, this gets very technical and can be very overwhelming for people with Duchenne. Next slide, please. So what we did is we set up a working group to discuss how can we make a family-friendly version of all these that service users can easily absorb information-wise. It was agreed when we set up this working group that people retain information very differently. So even if we set up put together a document that maybe encompassed just the bare sort of summary, it still can be quite daunting, especially because there's so many different facets to multidisciplinary care for people with Duchenne that doesn't apply to every individual because they're all unique. So what we agreed was to create short videos of each specialist area, including one for the therapist guidelines that was added on once it was published. Each video is about 5 minutes long, and the main aim of them was to really focus on what are the 3 to 5 points a person with Duchenne needs to be aware of. So if they're going to a non-specialist like a physio, or if they're in our accident and emergency room, they can then say, you know, this is the bare minimum that I know I should be aware of, or that I should be accessing. So today I thought I'd give you a bit of an example of 2 of the videos that we've put together. And after seeing a few of the presentations, I'm glad I chose these ones, because we also have one on bone health and respiratory, but I feel like a lot of that's been covered today. So if we go to the next slide, I'll give you an example of one that we did for palliative care, who's Professor Derek Willis, who was very kind enough to come all the way to Birmingham to record this with us. So I'll let Suzanne play this one.
Hi, my name is Professor Derek Willis, and I'm an adult palliative care physician, and I work in Shropshire. I'm a medical director of a hospice there, but also as part of my job I work with a local neuromuscular centre. So I've developed several years experience now of working with patients with Duchenne muscular dystrophy, but also the wide range of muscular dystrophies that people suffer from. Now the first thing to say is, and the take-home message is, don't panic. Because your perception might be that when we're talking about palliative care, that all I'm going to talk about is death and dying. And actually, there's loads of other things that we in palliative care think that we can actually offer people who are adults who are suffering with Duchenne muscular dystrophy. So, 2 things that people generally think of when they think of palliative care. The general public As soon as you use the word hospice, because people probably wouldn't know what palliative care is, they would think that hospice is a place you go to die. Now, that's probably true in the 80s, but now where palliative care has reached is that we're trying to have more of a positive aspect, where most of the people that we have in a hospice are those people who need symptom control. So what we're trying to do is to improve people's quality of life and get them to live well with a disease that they know is life-limiting. The second thing that I'm guessing for people who've got experience of Duchenne muscular dystrophy, either as someone who has the condition or a carer or a family member, is what children's hospices do, which is a really important role of providing respite for families. And that isn't something that adult hospices generally do. A lot of the treatments that are there for Duchenne muscular dystrophy mean that people are living longer. So people like me are now starting to see people who have Duchenne muscular dystrophy. So it's raising challenges about what it is that we can do to help support families and patients who have this. And the North Star document that's been written for adults has palliative care in that. And I've been part of the team that have helped to write that. So if your neuromuscular team suggests that an adult palliative care physician becomes involved, I think there are 4 things and 4 categories that it might be that they're going to be involved or be able to help you with. So the first thing is symptom control. Now we know that a lot of people who have Duchenne muscular dystrophy, particularly in the later stages of the disease, suffer with symptoms, pain in particular, but also there can be gut problems, people can feel nauseous. That is the kind of thing that is bread and butter to a doctor like me, where most of what I do is to give medication and alter wheelchairs and environments to help people to improve their symptoms. So it may be that your neuromuscular team is asking for someone like me to give advice about what symptoms people have and how we can improve them. So the neuromuscular team are experts in the disease process of Duchenne muscular dystrophy. I'm an expert in symptom control, but the person and the family and carers of someone who has Duchenne muscular dystrophy are experts in what it's like for them to have that condition. We're trying to treat symptoms. It's the 3 aspects that we're trying to bring together to help someone have a better quality of life. So 1, symptom control. Number 2, what we're actually talking about sometimes is providing spaces within adult hospices. So people who have Duchenne muscular dystrophy often want to meet together, and the adult hospice will provide you with a space. So we won't get involved, we won't do anything. We just provide our space for you guys or people with Duchenne muscular dystrophy to meet. And there are some hospices throughout the country that are starting to do this and are really enjoying doing it and getting positive feedback from users of the group. So it might be that you're being referred because there's a group in your area. And if not, it might be that you want to knock on the door of the local hospice to ask why they're not. So symptom control, secondly, a space to be, and thirdly, advanced care planning. What advanced care planning is trying to do is to say, it might reach the point where you're unable to tell us what you want, what your treatment priorities are if you go into hospital. So that's either because the condition has reached a stage where you can't, or you're in such pain, or you've got breathlessness and you can't talk properly. What an advanced care plan is trying to do is to write down what it is that you would want to happen, what it is that you wouldn't happen. So when you're in that position where you can't tell us or tell your family, we've all got a bit of paper that says, these are the things that I'd like to do, and these are the things that I don't want to do. So it's your written way of representing yourself when you're unable to verbalise that. So advanced care planning can be something that your team could do, but also could be something that palliative care doctors can help with. So I've done 3 things and I've not mentioned death yet. So it isn't just all about death. So the 4th thing is to say that there are some people who reach the end of their disease process, and we talk about what their preferences would be for where they would want to die. Adult hospices, their focus now is very much trying to support people at home, and we will be able to provide carers and support for people to stay at home to support your family and you, if you are someone who has Duchenne muscular dystrophy, if that's where you want to be. But there are some people who don't want to die at home, who want to be in a neutral space so that the home isn't somewhere that the remembrance of the death is there. And adult hospices can provide that safe space for patients to die in. So, I have mentioned death, it's part of it, but it's not all of it. We've got symptom control, we've got a space to be, we've got advanced care planning, and we've got end-of-life care. So, take-home message. If you get referred to a palliative care doctor, don't panic. It's not all about death, And some of this is us trying to understand what we as palliative care physicians can offer to the community that is Duchenne muscular dystrophy. Thank you so much for listening.
So yeah, that's one example, and I think it really mirrors that a few of the videos aren't very technical. It's very supportive of the patient. And then if we go to the next example, this one is a slightly more technical, just to show how we were trying to showcase a bit of a balance. So if you go to the next slide, yeah, and then we've got the lovely John speaking.
My name is John Burke. I'm a consultant cardiologist based at the Freeman Hospital in Newcastle on Tyne. So what I want to talk to you about today is the effect that Duchenne muscular dystrophy has on the heart. In Duchenne muscular dystrophy, the heart is uniquely vulnerable to damage on a day-to-day basis with excessive need for repair. So it's best to think about the heart as being built like a stack of cards in Duchenne dystrophy. It weakens over time in everyone with Duchenne, although there's some variability about the age at which this begins and is detectable. Symptoms have nothing to do with this. The heart would need to be at rock bottom in terms of its pumping function before a patient would be aware of any heart-related symptoms. So to pick up whether the heart is becoming affected and whether the heart is weakening or how it's responding to treatment is only decided on the basis of heart scans and other tests. The most commonly used test is an echocardiogram. That's an ultrasound scan of the heart, which takes about 30 minutes to do, is quite painless, and it gives a whole range of heart functional measurements. And the idea is to compare the results from one assessment to the next one to detect any changes. Increasingly, however, we tend to recommend heart treatments to boys with Duchenne dystrophy no later than age 10. This is because the commonest age, or the average age, for picking up heart weakness is around the age of 13 years. And so starting treatment protectively or prophylactically is actually beneficial in slowing the overall process. When a boy reaches the age of 10, if they're not on treatment already, and even if their heart tests are entirely normal, we tend to start one particular family of drugs called ACE inhibitors. There's a whole range of these. They're very well tolerated, and we tend to prefer a once-a-day medicine. If the heart is abnormally fast, as often is the case in Duchenne dystrophy around this time, then we add a second medicine, a beta blocker, to complement the ACE inhibitor, slow the heart and make it more efficient. And by the time the heart is showing any signs of weakness in terms of its pump action, then a boy would typically be on 3 medicines, the third one being something to block scar formation within the heart itself. So the take-home message is that your heart will become involved at some stage. The treatments which are well tolerated benefit the heart, support it for as long as possible, and need to be started early for their best benefits. So the message I want to leave you with is that be sure you're getting heart checks from an early age, essentially from diagnosis, and that there's a cardiologist involved in your treatment so that you can get the very best out of the medicines available and have the heart protected for as long as possible in Duchenne dystrophy. Thanks very much for listening.
Brilliant. Thanks, Susan. Can we go to the next slide, please? So as next steps, next, please. So we've sent all these videos to the working group, and it was overwhelmingly positive. They really loved how it was broken down, how simplified it was, but how clear and helpful at the same time. In fact, some of the things that they said were, Susan, how engaging and refreshing these videos are, because it's quite a different approach to putting together a family-friendly version of something rather than always a written document. How it breaks down what they need to know, and how one of them felt empowered now to direct these videos to their non-specialists, which is what we really wanted to see, is how patients feel a lot more, you know, knowledgeable of their own condition, but also able to take control and be a bit more self-management. So going forward, we are going to put these on our website, and it's launching soon, and they're also available on our YouTube channel, so people can watch either whichever ones they choose as on the webpage, or they can watch it as a playlist on the channel. We're also advertising it through our social media channels over the next few weeks, so please keep a lookout for all of our engagement. And throughout the next few sort of projects that we're coming up, we'll probably be taking tidbits of all of them to keep promoting it, so that people are as aware as possible about the care guidelines, because it's not just important for clinicians to be aware of them, but also for patients, so that they know what access to care they should be getting. Next, sorry, Sian. This is a bit of an example of what the webpage is looking like at the moment. As you can see, that all the videos be under each other, so you can pick and choose, but we thought it was a very clear way of presenting them, and a lot easier than for people needing to find different web pages and making it a bit untidy. So again, the feedback here has been really positive, and hopefully it really helps service users as much as possible. But either way, thank you so much for listening and looking at these videos. I just think it's amazing that if we can get as many people to watch them as possible, because I do think it'd be as helpful as it can be. But I also want to say a massive thank you to Ros and all the other clinicians that have been involved in filming and, you know, preparing the document and just putting it all together, because it's been a lot of work and they've really sacrificed a lot of their time to put an effort into this. So I really appreciate it, and say massive thank you also to you for listening.